Mm-hmm. Are we live right now?
Allegedly, but no.
While you're doing that, I'm just going to go grab one little prop I think would be helpful to keep me on track. We're live? Okay. Hi, my name is Carrie Andreu. I am a urogynecologist here at Health First. I have offices here in Vieira, where we're at right now, and then also at Gateway. I want to thank everybody for joining in for our talk tonight. It's pretty informal, and what we're going to try to cover, the topic being breaking up with the bathroom. So we're going to just have more of a conversation. I'm going to go over some of the more common types of urinary issues, urine leakage, go over briefly what causes them, and then some things that we do to treat them. This is just to kind of keep me on track, and then also to give you an idea, you know, we follow a pathway that kind of helps us in the management of all of these conditions. So I'll start by just saying that urinary incontinence in general is very common. You know, it's all I do, and I have you know, 2 other people here that do full-time urogynecology as well. So all we do is urinary incontinence and prolapse. So that's how many people deal with this on a daily basis. I'll give you a little bit of my background. I did a 4-year residency in OBGYN. I did that at the University of Cincinnati. I then did a 3-year fellowship in just urogynecology. So that specializes in just prolapse, so pelvic organ prolapse, and urinary incontinence. So if it's leaking or if it's falling out, then we can fix it. And then worked in Arkansas for about 5 years there in a private practice setting, and then came here. Dr. Tu, the other urogynecologist here at this office in Vieira, and I trained together, so I came to join her. And I've been here coming up on 2 years. So to start with, we'll just kind of go over the 2, I guess, main types of leakage. And usually I talk a lot with my hands, and I usually have a lot of pictures and props, so I'll just try to kind of be descriptive. But there's 2 main types. There's what we call stress incontinence, and then there's what we call overactive bladder. So I'll start with stress incontinence. Stress incontinence is a muscle problem. So essentially what that means is that when you put physical stress, not emotional, but physical stress on the bladder, so you cough, you sneeze, you exercise, you pick something up, anything that puts pressure on that lower abdomen, what should happen is that the muscles in the vaginal area should be able to clamp down around that bladder so that it doesn't matter if you're jumping on a trampoline with a full bladder, nothing's coming out. So age, wear and tear, all of those things can, you know, wreak havoc on those muscles. So, you know, I see women of all ages. So there are some 20 and 30-year-olds that, you know, after pregnancy and childbirth, you know, especially if they've had twins or a particularly traumatic vaginal delivery, They can have some issues with stress incontinence. And then menopause is another big culprit. So, the loss of estrogen can cause a real decrease in the muscle mass in the vaginal area, among other things. And so that's another time where stress incontinence in particular becomes an issue. So that's what stress incontinence is, or some of the symptoms that are associated with it. So then how do we fix it? So I'll move through the treatments, kind of going from most conservative to most interventional. So to start with, stress incontinence is a muscle problem. So there are, as strange as it may seem, several really good pelvic floor physical therapists in the Melbourne area that only treat pelvic problems. So that includes stress incontinence. And a lot of people think, well, I already do my Kegels and it didn't work. But it's kind of like going to the gym and you walk the track a couple of times versus having Serena Williams trainer. So there's going to be a difference. And I know from my office, and when I see people here, a lot of people, when they're doing Kegels, they're doing really good butt and thigh exercises, but you're not really isolating those muscles that are involved in making sure that you don't leak. So you don't necessarily have to go, every week or twice a week, kind of like when you're rehabbing a shoulder or a knee, but it is really helpful, especially for younger women who may want to have more kids or aren't ready to jump right into surgery. You can really go and get a lot of improvement by doing the correct exercises on a regular basis. So it's not overnight, but there's really no downside to building up that pelvic floor and building up those muscles. So that's the first thing that is out there and that we'd recommend. After that, depending on, again, how aggressive you want to be, there are what they call incontinence tampons that are marketed and available, obviously, over the counter. So the most common one is by a company called Poise. They're the same ones that make the pads. And they have actual tampons that you can use that will put pressure again on that urethra and bladder to try to prevent leakage. This is helpful, I think, for women who, again, maybe they have more mild leakage, but it bothers them. So, when you're trying to, especially after you've had a baby, you're trying to get back in shape, lose some of that baby weight, and you want to start an exercise program, but every time you go try an exercise program, you leak. So those are really good because you can take them in and out and they can work, in specific areas. So when you're trying to exercise, you'd put one in, stop the leakage, and then, but it's not something you necessarily have to wear all the time. On the other end, there's something that's called an incontinence pessary. And that is a disc that has, it's hard, if I don't have pictures, but it's a disc and it has a little knob on there. And it inserts into the vaginal area again, and it puts pressure on that bladder and urethra. And typically, I can teach people how to take it in and out themselves, or you can just leave that in place, and then every 3 months you'd come into the office, we take it out, clean the vaginal area, and put it back in. And in between, you just forget about it, because if we can find a incontinence pessary that fits correctly, then you shouldn't know it's there. So it's not something that's uncomfortable. It's just fit in the office. You come in, you have it done, you go home. So those are also non-surgical or non-procedural options to treat stress incontinence. Then we move down to there's surgery and then there's procedures. So the in-office procedure is something that's called urethral bulking. And urethral bulking is essentially like getting fillers that you get in your face, but you're going to get them in the urethra. So if you get fillers in your face, they're going to use like a silicone gel, and it kind of plumps up that tissue and pulls water in, and it just makes everything just a little bit bigger. So the same goes actually in the urethra. So if you remember, stress incontinence is when you put physical stress on the bladder. The muscles in the vagina are not able to clamp down so that, you know, that pipe is partially open. So now when you put pressure on that, then water can leak through that pipe. So then what we try to do with the urethral bulking is to go in the office with a camera, and we go into the urethra, that tube that's too open, and we're caulking that pipe. So we use that filler and we fill in that pipe to kind of close the lumen. So now that pipe isn't so wide open. So, you know, it's not so wide open, so less urine, hopefully no urine, can leak out with activity. The benefit of that is that it's an office procedure. So there's no downtime, there's no incision, there's no anesthesia. So you come in, you have it done, you go home. The flip side of that is that it's not necessarily permanent, it's not for forever. So, you know, that filler over time will lose its ability to kind of pull water in, so that tissue won't be quite as plump anymore, and then, you know, that pipe may start to open up some. But that's where something like the physical therapy and the exercises can come in, because if you build up that pelvic floor and those muscles around it, then even if you start to lose some of that mass from the fillers, then you have those muscles there to help close off that urethra. So that's always a nice combination as well. The time it usually lasts for is give or take about a year, is when people will start to see symptoms. But, you know, sometimes it'll last longer, sometimes not so long. And then lastly, with stress incontinence, we have surgery. In surgery, the gold standard for surgery is something that's called a mid-urethral sling. And a mid-urethral sling sits just that, under the urethra. So it is a surgical procedure. It's typically an outpatient surgical procedure. So you come into the OR, you have it done, and then you go home the same day. It usually takes less than an hour to have the procedure done. There's about a 2-centimeter incision that's inside the vagina. So you typically just have 2 tiny little stab wounds on the outside, but the one larger incision, about 2 centimeters, is inside the vagina. So as far as pain goes from surgery, there's not a lot of pain associated with it. And the way that the sling works is that it's going to support that urethra. So this is where those muscles should be to be able to clamp down around the urethra. But now we have that sling that sits kind of like a V to help support, so that, you know, even if you put pressure on here, that sling's there to stop the flow of urine. Like I said, it takes about an hour. You go home immediately after surgery. There are restrictions after surgery as far as, you know, lifting and bending, because we want that sling to heal in place. The success rate of the surgery is typically about 85%. It's safe. It's a pretty straightforward procedure, and is considered the gold standard as far as treatment for stress incontinence. So if you are, you know, really bothered by the leakage, it is a good option for a lot of people. And I guess that's something too that I should have kind of said at the beginning. Everything that I do as a urogynecologist is going to be based on quality of life. So, you know, with urine leakage, it's based on how much it bothers you. So for some people, it really bothers them if, they have leakage when they try to run or they try to exercise. For other people, it's, that leakage really doesn't bother them that much, and it's only when it starts to, really have large volume loss or leak through their clothes or something that, it's really starting to impact their quality of life. But that's really the bottom line. If it's impacting your quality of life, then, there are ways that we can intervene, either conservatively or, more, surgically to treat it. But it's based on your symptoms and how much it bothers you. So the other more common type of leakage, so that was stress incontinence. And then we have overactive bladder. I guess the other thing I'll kind of back up is that there are tests that we can do in the office. So things that we can do to test to see what type of leakage you have. So there are, like I said, in-office tests, and it just allows us to get some objective data to really see, is your leakage coming from stress incontinence or is it coming from overactive bladder? Because they both, in the end, will cause urine leakage, but because they cause them for different reasons, we have different treatment algorithms. So, you may have had treatment for leakage in the past, but felt like, it didn't work, and so now nothing's going to work. But maybe we didn't have an accurate diagnosis, so the treatment didn't work because we weren't treating the right type of leakage. So that's something else that I think that we can offer here, is to really get at what's causing the problem, so then we can have more effective treatments for it. Okay, so then we have overactive bladder. And overactive bladder is more of a nerve problem. So stress incontinence was a muscle problem, so overactive bladder is more of a nerve problem. And that is more of the, oh my gosh, I have to go and I have to go now. So a lot of times people will complain of frequency, so you feel like you're going every hour on the hour, you're getting up 4, 5, 6 times a night. Every time you walk into a mall, back when we used to be able to go shopping, you'd map out all the bathrooms before you even started going anywhere. Before you leave to get in a car, you go, and then every 20 minutes when you're on a car ride, everybody knows that they're going to have to stop. So those are all symptoms of overactive bladder. It can also be where, you can be in aisle 6 at Walmart and all of a sudden you get that urge to go and, you can't make it to the bathroom, and so then, you have a really embarrassing moment in the middle of Walmart. And the reason is that the nerves that innervate the bladder in overactive bladder are just that. They're overactive. So, it's like having a seizure disorder of the bladder. So what should happen is that as the bladder fills, it sends a signal to your brain, like, okay, starting to get full down here. And then the brain says, okay, relax, and so on and so forth. Well, in overactive bladder, the brain and the bladder don't really communicate well anymore. So those nerves that innervate the bladder just start firing. And, whether you're at home or, in the middle of the grocery store, if the nerves of the bladder start firing, then the bladder is just going to do what it's physiologically programmed to do, which is to contract. And if the bladder contracts and there's urine in the bladder, then that's an involuntary contraction and you won't be able to stop that. So, there's no way. It's like if somebody has a seizure, you can't stop a seizure just because you want to. So that's what's happening in the bladder as well. So treatment for it. Again, we'll kind of start with conservative and sort of work our way up. So the first thing to recognize in overactive bladder is that there are things, food, drink, that will make overactive bladder worse. So most people have had some kind of a heartburn, or they know somebody that has bad heartburn. And so if you have a lot of heartburn, you know that there are certain foods and drinks that tend to be notorious in making that worse. You know, pizza, you know, I mean, just whatever it is that does that. Well, the same goes with the bladder. So everything that you eat and drink is going to be broken down and filtered through the kidneys into the urine. So things that break down into more acid components are going to be more irritating to the bladder. So that tends to be coffees, teas, sodas, citrus foods, so oranges, orange juice, lemonades, tomato-based foods, so barbecue, pizza, pasta, vinegars, anything spicy. All of those tend to have more acid in them. So when they break down, they make the urine more acidic, and then they can cause more urgency, frequency, and overactive bladder. So that's not to say that, you know, like somebody like myself who drinks an inordinate amount of coffee has to necessarily give that up. However, if you're somebody who has urgency, frequency, or overactive bladder, and you're about to get in the car to do a 12-hour car ride, that's probably not the day that you want to have a lot of coffee, because you're going to have a lot of frequency then. So it's not causing damage, but it is going to make your symptoms worse. So the next step, or I guess option, again in kind of that non-interventional conservative category to treat overactive bladder, is again the pelvic floor physical therapist. So there are little tips and tricks that you can do. If you contract certain muscles in the vagina, it will reflexively relax the bladder. So that's really helpful if you are in the middle of the grocery store or something like that, and you get this sudden urge and you're kind of paralyzed because you're afraid you're going to, you know, just wet everywhere. There are ways that you can try to contract certain muscles to relax that bladder so that you're able to get to the bathroom and empty before you have some kind of embarrassing situation. So pelvic floor physical therapy is also helpful. The next step in treatment for overactive bladder are the medications. And there are a lot of medications out there. Each insurance will typically cover 3 or 4 medications, so there's no reason to ever break the bank and having to start one of the medications. There are a lot of studies out there where they've tried to compare different medications, and there's not any data to show that one medication is necessarily superior over another. However, just anecdotally, people sometimes do respond better to one medication, or, you know, are unable to tolerate another medication. So, you know, that's something that we can always play around with. So, you know, that would be the next step in the treatment for overactive bladder. And typically what we'll do is we'll start a medication, give it, you know, about 8 weeks, 2 months to see where you're at. You know, did it help? Sometimes we'll have you keep a bladder diary for a couple of days just to kind of look at the frequency there, how many times you're getting up at night. And then we'll kind of come back after a couple of months and decide, do we want to try a different medication, go up on the dose, or move down to some of the other options. Kind of backing up, I guess one other thing that I forgot to mention when we were talking about diet, one of the more common complaints that I get that people will come in with is that they're getting up a lot at night. And you know, there's a lot of different reasons why people may get up 3, 4, 5 times at night to go to the bathroom, but one of the easiest things to try to do is to really limit your fluids 4 to 5 hours before bed. So if you go to bed at, you know, let's say 11 o'clock, then anytime after, you know, 6, 7 o'clock, you really would be conscious of, you know, sips of water, maybe with your nighttime medication, and then really limiting your fluids outside of that to try to decrease the amount of times that you get up. Okay. So then with overactive bladder, if we've tried the medications, we've tried some of the lifestyle things, and you're still having issues, then we have 3 options as far as treatment goes. The first is InterStim, the second is Botox, and then the third is tibial nerve. So we'll start with Botox. Botox is just that. It's Botox for your bladder. So Botox will paralyze any muscle that you put it in. So if you put it in your forehead, you're not going to have wrinkles because you can't move your forehead. Botox is used for a variety of medical issues. So it's used for migraines, it's used for cerebral palsy. So it's used in a lot of different areas. And it's not the type of thing that you inject in one area and then it migrates anywhere else in your body. But in the bladder, what is happening, just like we said, is that those nerves are firing and the bladder's responding. So it's having these seizures. So what we're trying to do with the Botox is to partially paralyze that bladder. So now, even if those nerves are firing, that Botox is there and it's causing a partial paralysis of the bladder, so that even if the nerves are firing, the Botox won't allow the bladder to have as severe contractions. Now, obviously, we put enough in so that it would adequately treat your symptoms, but not so much that your bladder is completely paralyzed. The benefit of something like bladder Botox is that it's an office procedure again. So, you come into the office, we do it right here, you go home, and then you're done. Typically with Botox, it lasts around 6 months. So twice a year, you come into the office, you have the Botox, and then you go on your way. So it really is a nice treatment for overactive bladder for a lot of people. Then there's something that's called InterStim. And InterStim it's like a pacemaker for your bladder. And so what it is, it's a little battery. It's about yay big, and it sits underneath the skin in the upper buttocks, kind of lower hip region. And then there's a wire that goes from the battery, and it sends little signals to the nerve that innervates the bladder. It's a 2-step process. So the first step we typically do in the office. And so the nice thing about that is that the first step we put a temporary battery and a temporary lead. It's about the size of one of your hairs. And we monitor your symptoms. So we'll have you keep a bladder diary for 3 or 4 days, and we look to see if it's going to work. So you don't go through with the procedure unless you know that that's going to work for your symptoms. And if you come back and it works and you had improvement, you're not getting up as much at night, you're not having as much frequency, you're not having accidents, then we go to the operating room. It's about a 45-minute procedure. We make about a 2-centimeter incision. We slip that battery underneath the skin. The wire goes underneath the skin. And then we program it, like I said, to send those little signals, and then you're done. The nice thing about InterStim is that, you don't have the procedure done if you don't know it's going to work. So going into it that it's going to be a successful procedure to treat your symptoms. And the battery life is typically about 7 years. So if you have it done and it's successful, then you don't necessarily have to think or worry about anything bladder-wise for, 5, 6, 7, 8 years. So for a lot of people, it's a very nice option, and it treats a variety of, bladder issues. Today we're talking about, overactive bladder, but it's also used to treat urinary retention. It's used to treat fecal incontinence. It's used to treat overactive bladder, because those are all the same nerve that innervates for all of those different disorders. And so, InterStim is a good tool to treat all of those. So that's InterStim. We talked about bladder Botox. So the last treatment option that we usually do or offer for overactive bladder is something that's called tibial nerve stimulation. And that is, it's kind of like having acupuncture for your bladder. And so the bladder nerve, it comes out of the back, sort of in the lower back region. And that's where we access it for interstim. And then it'll come around and it innervates the bladder, and then it travels down the leg and ends right here behind the ankle bone. So that's where we access it for tibial nerve. And what it entails is that you would come into the office, you bring a book, you bring your iPad, whatever, and we use an acupuncture needle, and we place the needle behind the ankle bone here. You have a little grounding pad on the bottom of your foot, and then it's like a little TENS unit, and it sends little signals through that acupuncture needle, and then you just kind of put your feet up and you are in the office for 30 minutes. So each treatment session is 30 minutes. And the entire treatment, I guess, timetable for tibial nerve is 12 weeks. So you come in once a week for 30 minutes for 12 weeks. And then at the end of 12 weeks, we typically will do a maintenance program. So you'd come in like once a month and have it done. But the main bulk of the treatment is that once a week, 30 minutes for 12 weeks. It's an acupuncture needle. It's not painful. And so the benefit is that, it's a pretty benign treatment. It does work really well. But not everybody has the time to devote to coming into the office 30 minutes for, that 12-week session. So I think that about covers our kind of, types of leakage. I guess sort of as an aside, one of the things that we'll do when you first come into the office to, discuss urinary leakage is to do a full exam, because, overflow incontinence can also cause leakage. And what that is essentially urinary retention. So you're unable to empty the bladder. And so if you have all of this urine in your bladder, then that's going to slowly leak out. And you're going to have a lot of frequency because you're not emptying all the way. You're going to have a lot of urgency because the bladder's always full. And that can be, either a nerve problem, that the bladder's not contracting like it should, or a lot of, commonly, especially in my practice, what we'll see is, prolapse. So if the bladder's falling, if the uterus is falling, then that can also kind of push upon that bladder and then not allow it to empty as well. So, sometimes fixing the prolapse or something like interstim, or, there's a number of different things that we can use to treat urinary retention. But that can sometimes, present as urine leakage, but in reality, it's just the inability to empty your bladder. So I think that kind of covers the two main types of leakage that I see on a day-to-day basis, the overactive bladder and the stress incontinence. I think that the way that this works is that there's a comment section on the bottom. And so if you have any questions, or if there's anything that maybe I wasn't clear about or that you want more information on, you can just write it in that comment section, and then there's some people here that will read the comments, and then I can just address those questions as they come in.
People can also email urogyne@hf.org.
Oh, okay. So another way that you can present your questions, if you have any, is if you email Urogyn, UROGYN, @hf.org with any questions or comments. Then we can also check those, and then I can answer any questions that way as well.
So, question from Rachel: is incontinence a problem seen in diabetes?
Oh, okay. Yes. So diabetes is actually a pretty common cause of urinary incontinence. So, one of the issues with diabetes is that it can, over time, all of that excess sugar cause the nerves that innervate the bladder to, break down and not work as well. I think diabetes does that to a number of different organ systems throughout the body. So if it starts to cause the nerve that innervates the bladder to not work as well, then that can result in overactive bladder a lot of times. It can also cause a lot of recurrent urinary tract infections. Urinary tract infections can a lot of times present as urinary incontinence. And then if the nerves that innervate the bladder are not working as well, the other thing that can happen is that those muscles don't work as well. So you need, nerve intervention for the muscles to be able to contract. And so if they're not able to contract, that can lead to stress incontinence. So, diabetes can result in a lot of different types of leakage. And so that's one of the things that I'll usually cover if somebody has, that listed as a diagnosis, kind of look to see what your A1C is, what do your sugars usually run, and trying to get that treated while we move on and try to treat some of the leakage as well.
Question from Jen. Can I get laser therapy if I'm planning to have more children, or should I wait until after I'm done?
Oh, okay. Yes, you know what? Thank you. So I didn't cover that. So one of the other treatment options that we have here in the office, and we just started offering it here at the Vieira office, so I'm sorry I didn't cover that, is something that's called, it's essentially a vaginal laser. And vaginal laser works for a number of different diagnoses. So it can work for painful intercourse as well as urinary incontinence. And so just kind of a general overview of how the laser works is that if you cut yourself, so the way that your body is going to heal that is that it's going to come in. So when you cut yourself, it gets kind of red and swollen, and that's because your body is literally bringing in new collagen, new extracellular matrix, elastic tissue to lay down new skin. So one of the things that can happen either after pregnancy and childbirth with the kind of flux in hormones there, you get a decrease in estrogen levels. And then with menopause is that, that tissue becomes less elastic, you have less blood flow, and that can result in both stress incontinence and overactive bladder. And so what the laser does is it goes in, it's a tube that will go into the vaginal canal. You don't have pain fibers within the vaginal canal, so those aren't, you don't feel things the way you would if somebody were to, do like a laser treatment on your face or, on your chest. So the tube goes into the vaginal canal, and then the laser slowly circles around and treats that vaginal canal. And so what it's doing is that it's just causing very superficial micro traumas. So it's not really puncturing that vaginal tissue, but it's just enough so that the body thinks that there's been an injury. And so if the body senses that there's an injury, it's going to fix it. And so the way that it fixes it is the same way that it's going to fix it if you have a cut on your arm. It's going to send in extra blood that is going to bring in more collagen and elastic fibers and literally lay down new tissue. So we do a series of 3 treatments. Each treatment is about a month apart. And over the course of those 3 treatments, that tissue will go back to a non-injured, premenopausal, pre-pregnancy type of tissue. So it's rebuilding all of that muscle, all of that tissue there, so that not only will it take care of some of the dryness and painful intercourse, but by rebuilding those muscles and increasing the blood flow, it will treat mild stress incontinence, because stress incontinence, like we said, is a muscle problem, and also some overactive bladder, because by losing some of that estrogen, that will contribute to overactive bladder as well. So it it can treat all of those. It's a really good treatment for, well, for a variety of women, but the question specifically was saying, can you have a laser treatment if you wanted to have more children? And so the answer is yes. So, one of the types of issues that I will come across in my office is, somebody who's had, maybe one kid, twins, traumatic childbirth, and so now they're in their 30s, they're trying to exercise, get back to, their pre-pregnancy self, but they're having all of this leakage and they're having, issues every time they try to, exercise. And so surgery, if you want to have more kids, especially if you're young, isn't a great option in that scenario, because if you do get pregnant again and have another childbirth, then that's going to damage the surgery that we do. So something like a vaginal laser that will naturally rebuild that tissue in there and allow you to kind of rebuild that muscle mass on your own is something that isn't going to hinder your ability to get pregnant or have more children, and can allow you to then treat some of that leakage and overactive bladder without any detriment if you want to have more kids in the future.
So a similar question from Laurel. My PCP says he has a laser that can treat my incontinence. Will this work?
So, I guess the answer to that is this. There are a lot of different lasers on the market, so it's hard to say what type of laser is out there. Not, I guess not all lasers are designed to treat vaginal tissue. One of the other benefits, I think, to coming to a specialist like myself, Dr. Tu, Dr. Raiders, who specializes in urinary incontinence and pelvic organ prolapse, is that we have the tools and the knowledge to really assess, to find out why you're leaking, what's causing the leakage, and then to decide what the appropriate treatment would be. In some cases, maybe a laser would be an appropriate treatment, or at least one of the appropriate treatments. But there's a lot of instances where maybe it's not. And so that kind of goes back to what I was saying with some of the testing that we do and the full pelvic exam and some of the measurements. We're able to really get kind of a full picture of what's causing the leakage, and then to really go down those treatment paths so that you're not, getting things done and then feeling like, well, now nothing's working. Well, maybe it didn't work because you weren't treating the appropriate diagnosis. So I guess the answer is that, I don't really know, what lasers out there are designed to treat what. I just know that, if you were to come someplace like here, then we can appropriately assess and really decide what the best treatment would be.
From Rachel, how does incontinence relate to age?
So the biggest factor that age has in incontinence is menopause. So, there's 2 times in a woman's life where, we really see an increase in urinary leakage. And so that's in younger women after immediately after pregnancy and childbirth because of the strain on the pelvic floor, and then menopause. The decrease in estrogen, whether it's after a surgery, if somebody's had their ovaries surgically removed, or naturally if they go through menopause, but that really starts to make those muscles in the vaginal area very weak. They're not as elastic anymore, and so you just get a big increase in urinary issues, both urgency frequency because of the thinness of the tissue, both in the bladder and in the vagina, and how weak the pelvic muscles get. So that's usually the average age of menopause is 51. So that's usually kind of in your late 40s, early 50s is the time where we'll see an increase because of the lack of estrogen.
Are medications normally covered by insurance? I have Health First health plans.
So yes, there's a lot of different medications out there for overactive bladder, and insurance doesn't typically cover all of the medications, but each insurance plan will cover at least 3 or 4. And like I was saying before, there's not any good studies to show that one medication is necessarily superior to another. So there's no reason to break the bank in trying some of these medications to see if they're going to treat your leakage. So there's always going to be 1, 2, 3 overactive bladder medications that are going to be adequately treated on your insurance plan that we can use and try to see if they work.
Can incontinence be caused by infection?
So the answer is yes. The most common infection would be a urinary tract infection. So recurrent urinary tract infections are pretty common. Anytime you have a urinary tract infection, you're going to have urgency, frequency, and then most women are also going to have some kind of a leakage. So whether that's leakage with urge because of the infection, or if you have underlying stress incontinence, a urinary tract infection is going to make both of those conditions substantially worse. And so again, that's one of the things that if you were to come to see us in the office, that we would check for. And before we do any kind of testing, before we do any kind of interventions, we're going to treat the infection and then reassess to see what your leakage is, because that may be as easy as that we treat the infections. We put you on a regimen to ensure that you don't get further infections, and then you don't have any more leakage. So, okay. I think that will conclude our presentation for tonight. I want to thank you all for joining us. If you have any further questions, do they email or? Yeah, if you have any further questions, you can email us again at urogyne@hf.org, or call our office here at Viera to make an appointment, and we're always happy to discuss or go over anything in the office as well.